Welcome to This Just In, the show bringing you the latest advancements in healthcare, strategy, innovation, and public policy. And now, for the fastest voice in healthcare, here's your host, Justin Barnes.
Thank you for tuning in, and welcome to This Just In. I'm your host, Justin Barnes. In these segments, I'll bring you the latest advancements in healthcare, strategy, innovation, and public policy. As always, we're broadcasting from the This Just In studios on the Business Radio X network, as well as the HealthcareNOW Radio network. For this episode, my 177th episode, we have a great returning guest who's coming in for a second week in a row, Alex Lennox-Miller, Senior Analyst from Chilmark Research. Welcome back to the show, Alex.
Thank you so much for having me back. I'm really happy to be talking about this.
Yeah, in my almost 5 years of broadcasting this show, I've never invited a guest for back-to-back shows before. So it just shows how much great content and strategy, and I want to continue on the conversation, so for sure.
Yeah, I mean, it's something that I think could probably get talked about for hours. So
I agree, and obviously you come from Chilmark, great strategic insights. I've been reading your research for at this point decades. So great to have you back, my friend.
Well, thank you for having me back.
So let's dive right in. A little bit of a level set, and we talked about this at the top of the last show, but what are some of the drivers, in your opinion, for these new models of care in primary care, as well as hospitals and health systems? So let's just start there.
Well, some of them, are the same, right? The MD provider population generally is getting older. Some of the statistics we talked about last week, 52% of MDs are over the age of 55. The average age of retirement is, still 60, just around 64. It means that the provider population is aging. Providers are retiring more and more frequently. The replacement numbers for hospital specialties are a bit better than they are for primary care. Primary care is where the replacement, the new providers coming in just aren't graduating. They aren't going into those specialties. But that problem exists across healthcare systems. The other big issue is supply, just supply versus demand. I think we've reached the point where just telling providers to see more patients, have shorter appointments, churn productivity as much as possible has, hit the wall. You can't do it anymore. Arguably, patients are already experiencing appointments as too short. They aren't getting the care that they need. That's something that needs to be addressed. We've got to figure out how you can provide better care, how you can not necessarily see more patients, but at least see the patients that you've got that need your attention, that need your care in the amount of time that's appropriate. Just churning them through doesn't work. It didn't work. When that became the primary drivers in healthcare, and it doesn't work now. And trying to address that, trying to figure out what tools there are that can assist in that, what tools there are that can supplement that, and what the provider role really is I think the driving force behind most of these new models in primary care and hospital care.
Yeah, as we talked about in the last show, I had to take that on, personally here in Georgia, create a whole brand new health plan where, we put doctors in the center of the patient's care. At least the primary care doctor is kind of the quarterback for the care, and then we wrap a big network. But we really reduced costs by 30 to 60% by doing this, and then we just wrapped around. We put insurance in its appropriate spot. We put the care provider in their appropriate spot. They actually dropped down the panels, down to, I think we cap out panels at 700 patients. And today we see 5,000 patients on a panel, but we have 600 for a primary care physician. So
yeah, panel size is probably the single biggest issue for primary care. Yeah. The panels that they're asked to care for, the amount that they're asked to do for those panels, the numbers just don't add up.
Yeah, when you're dealing with chronic conditions and so forth, in which we are heavily, and really trying to reduce costs and improve quality of care, and you just can't do that in an average 7.7 minute appointment. Our average appointment's almost 52 minutes, and we want that. Our annual physicals are 2 hours long, and our doctors get to know the patients, and the patients get to know the doctors, and It really works, and it drives down cost. It's just not about seeing more patients, and it's because actually, we've just seen how that just increases cost. It doesn't actually reduce cost. It hurts care and improves the cost. So we went the exact opposite of that type of a strategy, and we're yielding some great results. So I love the direction that you're headed towards, certainly in your research. So,
well, I think the other side of it is that's where reimbursement is going now. Reimbursement is going to outcomes. Reimbursement is going to quality of care. Doesn't matter how many patients you're churning through,
right,
if you're not helping them, if they're getting readmitted, if they're having ED visits, if their health maintenance numbers aren't where they need to be. And that's the other issue that that health systems are struggling with, is that a lot of their models of productivity don't square with the direction that reimbursement is going.
So great point. So now moving into the kind of the innovation side, what innovations are you seeing in care design? We just talked about one, but what else are you seeing in care design or strategy that we should look forward to in the coming years from your research?
I mean, I think the biggest ones are the ones that give time back to providers in some way, whether it reduces the amount of time that they're spending on administrative tasks, whether it reduces the amount of time that they're spending during an appointment doing intake interviews and getting that background information that really ought to already exist in the clinical record or could have been collected maybe prior to the appointment. Things like telehealth, telemedicine, remote care, which don't necessarily make the individual appointment faster, but which take away some of those additional barriers, some of those additional obstacles, especially for patients. You're seeing more and more trending toward this. Humana announced their all remote care plan, for 2020, that I think is something that you're going to see more and more of. CMS announced their primary care first initiative, trying to drive some of this stuff to influence how primary care is conducted. And, like I said, those payment incentives are what's going to drive these new models, stuff that keeps patients at home, that prevents patients from needing to have, currently they're necessary because it's the only way that you can get information about somebody in a post-acute or a post-discharge setting is to have them come in. But if they have medical equipment at home, if they can get their temperature taken, if they can have something monitoring their vital signs, wearable technology that you can access the data from your office, you don't have to have them come in. Those are the things that are going to relieve some of that burden on providers by taking away some of the stuff that currently they're spending a lot of time on.
Yeah, I mean, even to that point, we've been able to reduce unnecessary visits with telehealth. Every member has access to their primary care physician via a telehealth app and a virtual care app, and they can ask questions, they can do secure messaging, they can do video chats with their doctor, not a doctor, but their doctor. And that really frees up those appointments to real managing the people that need to be in front of that doctor at that time. So, same-day visits or next-day visits, it really frees up the schedule for the patient as well as the doctor, and then allows the doctor and the patient to focus on the significant issues, the chronic conditions or the significant areas of care that need to be focused on. So, yeah,
I think you've really hit on the other thing, which is going to make a big difference, which is building applications and platforms that enable asynchronous communication between provider and patient. Right now, almost all communication that happens is synchronous in one way or another. If you can get people who don't need, an immediate call back, who don't need to be speaking to someone face to face, who, are comfortable just sending a message or getting feedback on a platform, again, that enables more or less the same level of care. They're not getting less attention. It's just adjusting how that time is spent, how their time is being spent, and what the provider has to spend time doing. If they're, a good doctor can do a chart review pretty quickly and get to the meat of the issue. If they don't have to do that at the same time that they're sitting in a room with the patient, trying to talk to them, trying to get, all the other parts of that appointment done, you can save a lot of time.
Yeah, great point. And I think one thing we brought forward, and I mentioned this in our last talk as well, is where our think tank came up, and we actually had one of the large health systems present how they did a study just around what patients want when it comes to telehealth and virtual care and different types of communication. And they actually want access to their doctor, not a doctor. And I think that's a big thing with a lot of these telehealth companies out there is they do offer telehealth with a doctor. They may or may not have access to your medical records. But when you ask the patient, they want access to their doctor via video chat or telehealth or virtual care, and they want their medical information available to that doctor making the decision. So their doctor and their healthcare, their medical record available. That's unique. We deployed that here in Georgia, but that's hard to do if you don't start from really redesigning the care strategy from the beginning.
It's hard to do, and it's easy to get wrong.
Yes.
I mean, this is I think the problem that you see in some of the telehealth deployments that are initially, because that was where the reimbursement, that was where the patient demand was, they were originally sort of focused on acute episodes, on on-demand care. That's kind of, I think, the issue you see with a lot of the retail and urgent care clinics that are out there. They offer incredibly valuable services. People want to take advantage of them. They're services that people need. But on the other hand, the more different networks that get involved in someone's care, the more, fragmented it is, the lower the quality of care is, and they don't have that kind of personal experience with a provider or a care team who knows them, who knows their situation.
Excellent. So even transitioning there, what are some of the concerns or risks that you see in these new models of primary care or in care in general?
I mean, I think that's one of them. The loss of that provider relationship of a longitudinal investment between a provider and a patient is valuable. It has real clinical value. It lets providers know what their patient's baseline is and lets them get familiar with what's going on, where are their potential needs and stresses. The other one is kind of similar, but I worry that a lot of these lower touch, lower patient involvement systems have the potential to not necessarily reduce burden, but just redirect it. If you've got a lot of younger patients who don't have significant chronic issues, who don't have a lot of health problems, and they're mostly taking advantage of retail health and telehealth, what you're doing is reducing some of that patient burden on providers. But on the other hand, those more complicated patients, the ones who need more time, who need more investment, you're shifting that burden back onto providers who offer in-person appointments. And something that's been seen in the NHS in the United Kingdom as they've started to offer telehealth systems. Those telehealth systems take the younger, healthier patients, which is good. That's probably the kind of care that they need. But it shifts a lot of that burden instead of relieving it. And that's something that I'm genuinely concerned about. If you take all the healthy patients away from a doctor's panel and replace them with half the number of patients, but who have significant chronic care issues, significant health issues, you haven't made their lives easier.
Right. Yeah, no, and I couldn't agree more. Just had a conversation this morning around a component of that with some healthcare strategies. So we're seeing some really cool, unique models certainly coming in 2020 by some of the larger payers and specifically around CMS, but we also see that selection can happen pretty quickly. And so I think it's something we got to keep a very close eye on.
Yeah, those patient populations self-organize really efficiently and really quickly. And if you aren't prepared for it or aren't thinking about it, whether you're an individual provider, who's thinking about offering this kind of service or a health system, if you don't offer those remote options so that you're retaining that healthy population and keeping it as part of your provider's panel, you're really going to be running those risks.
And for those joining us a little late, my guest today is Alex Lennox-Miller from Chilmark Research. And if you recognize Alex's voice, he is a returning guest. He's my very first guest that I've ever invited back-to-back shows, just because we had such a great conversation last week that I had to have him back. So Glad this conversation is continuing on. So let's switch a little bit over to best practices, something near and dear to my heart. I'm sure it is to your heart. It's part of my think tank. So let's talk about, starting off with patient engagement. So what patient engagement best practices have you seen or recommend to the industry?
I mean, I think that patient engagement has to start with shared decision making. That's the thing that has the most clinical proof to it for improving health outcomes, improving mental health outcomes, improving medication and process adherence, reducing ED utilization, reducing readmits, all those fantastic metrics that everyone is trying to improve on are all improved by engaging your patients in their own healthcare. Whether it's through really simple, conversation and discussion during appointments, whether it's through remote care platforms that give them a little bit more responsibility and more of a role in tracking their own stuff. Those are the things that make significant changes in clinical outcomes that I think are underappreciated in a lot of healthcare systems because they're just not part of the vocabulary that a lot of providers are used to.
And I completely agree. There's one of the strategies even 10 years ago when we started to, actually 15 years ago, when we started to really deploy personal health records and patient engagement platforms is, you want medication reconciliation, but as a starting point, you certainly can have the patients add their medications into the platform instead of, that was always how do we get all these drugs in there? How do we get the medications in there? How do we get the system? And we said, the patients are the cheapest resource in the physician practice, literally. Let them do, they know that a lot of the time, now, you have to verify, and you want to do reconciliation, but certainly let the patient add, I'm on 10 milligrams of Lipitor or whatever it is, whatever drugs they're on, let them put all that in there as a starting point. It's a great baseline. I mean, just a simple example, but we came, 15 years ago, we educated and started that process.
Well, and using that as a conversation starter, how does that medication make you feel?
Right.
When do you take it? How do you take it? Do you take it regularly? Those are the really basic elements of SDM that make a huge difference with patients feeling engaged, with patients feeling heard. It's relatively simple stuff, like you said, but it can make a big difference.
So in a strategic perspective, or from a strategic perspective, what best practices do you recommend or share with hospitals or health systems specifically? Because we're not building a whole lot of new hospitals. In some communities we are. For the most part, we're not. So what do you, when you go in there, what does your research say, or, what perspective do you take there?
From my perspective, the most important thing that these hospitals and these health systems have to engage in is not just deploying new technology, but deploying it in a really thoughtful, intentional way. And that has to start not with the decision that you're going to deploy technology, but with a lot of those really nitty-gritty process analysis, process redesign meetings, trying to really figure out not just, what product is out there that's going to make our current process easier, but why are we doing it that way? What really are our barriers or our pain points? And then once you figure those out, you can start looking at technology that's going to help there. I think too many health systems, too many hospitals find a technology that assists with something that they sort of generally know is a problem, but they don't know that that's going to solve their real issue. If you've got a bad process, right, and you're just trying to automate it because you've seen that this process is holding up other things or making things take too long, all you're doing is just doing something bad faster. You haven't really fixed the problem. So the single biggest piece of advice that I talk to whenever I'm talking to a hospital or a health system thinking about deploying new technology, thinking about new systems, is what specific problems does this fix? And you really have to get down to the specifics. It can't just be revenue cycle. Yeah. It can't even just be denials. Right? If you're talking about insurance, it has to be, this is going to fix the issues that we have with our physician coding acuity or something like that. You really have to get down to that level of specificity. And if you haven't, then you're really running a lot of risks as you go out and make these major purchases in capital, in human capital, in time.
Yeah, you made me think of something there. It came up in our think tank where people were trying to solve, or not really solve, but they wanted to kind of get into the virtual care or the telehealth type of strategy for their health system. And this is more on the health system side. But they didn't realize, and a lot of this failed out of the gate because they kept it totally separate from their care design and their care strategy inside the four walls of the facility. And so they really were deploying solutions that were failing because, again, you open up an app and they don't have access to the medical information, or they're not talking to their doctor. There's a myriad of reasons for failure, or it wasn't that helpful. It added a lot of cost and expense. We still were seeing them in the ED. It didn't help it didn't help reduce costs or increase access, or at least we didn't. Patients said it didn't. It didn't alleviate ER or our ER overload or anything like that. So all the metrics that they had set out, if they had set out metrics, they weren't achieving. It's because it was not integrated into the overall care design and care strategy for that patient as it touches the health system. That was a lot of health systems kind of stood up and said, yeah, we failed in that one, we failed in that one too. And when they integrated into the technology was integrated into the overall strategy for that patient, it went much better, and they saw much better results across the board.
And a lot of the time, if you sit down and you do that sort of grunt work ahead of time, you'll identify problems that you didn't know existed. You might have problems that are really easy to fix that don't need an expensive tech solution. You're going to identify stakeholders that you didn't know were involved. And if you get their input and you start talking to them, you're going to get a lot more clarity in how your operations are working, how you're serving your patients, how you're serving your staff.
So true. So moving into the lightning round, I got about 2 minutes left. I want to get to a couple questions. But real quickly, what are some of the best practices that you would recommend or share with independent physician practices? We talked about health system, but lightning round, but what would you say for real quickly for independent physician practices?
Well, independent practices face a lot of challenges right now. I think the best advice I would give to independent practices would be really hone in on what it is you want to do. Hone in on the kind of services you want to provide, the populations you want to provide them to, and figure out what those populations need. If you're offering, primary care to an older population group who's been seeing you for 10 years, what they want and the level of service that they need and the financial issues underlying that are going to be totally different than if you're in an urban area with a really young population. You can't treat all of these groups the same just because they all come under the heading primary care or they all come under the heading family medicine. You have to really look at who it is you're dealing with, who do you want to be dealing with, and what kind of services do you want to be offering them. Because if you don't have the answers to that, they're just going to go, anywhere they can.
And that's just good. That's just good general business advice. I mean, it doesn't matter if you're in or manufacturing or on railroad, whatever you're doing. Make sure you know what you want to do and how you can achieve it, and can you deliver it well? Your target market. No, that's just great advice. And I always like this last question. We got about a minute left, and just so my guests get to know you better personally. We didn't get to this last time, but we're going to get to it now. And in my closing segment, I always ask this question of my guests: what is your favorite place to get or be inspired?
It's outdoors. It doesn't even matter whether it's someplace rural or just getting out of the office and walking around downtown. But getting outdoors, getting into a totally different context does wonders for my thought process. The voice to text function on my phone has gotten such a workout because I live right near the Medford Fells in Massachusetts, and I go for walks and I go for hikes. And I can't count the number of times that I've gotten, really confused looks from people who have seen me sitting on a rock or a stump talking at my phone about, insurance policies and healthcare IT deployments. But something about changing that context really just gets my mind flowing.
I couldn't agree more. We're a lot alike. Outdoors is my answer, to be honest. I try to be on the water. If not, I go hiking and go on hiking in a couple of weeks. But I also warn all my friends and anybody around me, I do voice to text. It's just so efficient. I can get a lot more done. And it's, so I completely agree. But we are at time. So Alex, thank you very much for joining the show yet again this week.
Well, thank you so much for having me. I really love talking about this stuff, and it's been great talking to you about it.
Excellent. And we'll certainly we'll have you back. And thank you to everyone for joining us today. And please tune in weekdays at 2:30 p.m. Eastern, 11:30 a.m. Pacific to hear our latest shows. As always, you can track me on Twitter at HIT Advisor, and you use the hashtag ThisJustinRadio so you can respond to your comments from the show. If you missed any of this episode or want to hear more, all of my shows are posted on Apple iTunes, SoundCloud, iHeartRadio, Spreaker, Google Play, and TuneIn. And you can check out the new updates that we just launched at justinbarnes.com. Thanks, everyone. Have a terrific week.